Hello, everyone. Welcome to another time with Dr. Ifeolumeru and Okafor. This is Hematology and Blood Transfusion Lecture Series, a YouTube channel where we discuss different topics in hematology and blood transfusion science. We started a lecture series on hemostasis, and we've done primary hemostasis, where we talked about vasoconstriction and the role of platelet in hemostasis, talking about platelet adhesion, activation, and aggregation. If you have not watched that video, please go back to our channel. The link is placed here for you to click and then you watch it. It will help you to understand the topic that we have today, which is secondary hemostasis and fibrinolysis. Thank you for your support. Thank you for being part of what we are doing. Thank you for subscribing to our channel and sharing our lectures. If you have not subscribed yet, please, this is the right time to do so. Keep on sending your feedback and your questions. They are really useful to us. Thank you very much. Remember, today's lecture is titled Secondary Hemostasis and Fibrinolysis. Learning objectives. It is expected that at the end of this lecture, you should be able to describe the coagulation cascade and formation of fibrin clots. You should be able to explain the process of fibrinolysis and clot dissolution, identify key laboratory tests that can be used to assess secondary hemostasis and fibrinolysis, and it should be able to outline the regulatory mechanisms controlling the coagulation and fibrinolysis. Let us start by defining hemostasis. Hemostasis is a physiological process that prevents and stops bleeding from a damaged blood vessel while maintaining blood in fluid state and also keeping it contained within the circulatory system. The name itself comes from the Greek word hemo, meaning blood, and stasis, meaning to stop or to halt. So we have hemostasis, the physiological process that prevents and stops bleeding from damaged blood vessels, and also the same process tries to maintain blood in a fluid state and also try to contain it within the circulatory system. Hemostasis actually depends on two varying mechanisms, the clot promoting and clot inhibiting mechanisms, or you can say procoagulant and anticoagulant mechanisms. We have different stages of hemostasis. For ease of understanding, I divided it into four: the vascular constriction, formation of platelet plug, which can also be termed primary hemostasis, coagulation cascade, which can also be termed secondary hemostasis, and fibrinolysis, which can also be termed tertiary hemolysis. We have been able to deal with vascular constriction and platelet plug formation, which is primary hemostasis, in our previous lecture. Please do well to go back to our YouTube channel or click on the link that you are seeing now, and then so that you'll be able to watch that particular lecture. It will help you to understand what we are doing today better. Today, we are going to be focusing on secondary hemostasis and fibrinolysis. So, we are going to be starting with secondary hemostasis. Secondary hemostasis is the process of reinforcing the initial platelet plug with a stable, insoluble fibrin mesh. This process, also known as coagulation cascade, involves series of enzymatic reaction among plasma protein called clotting factors. This cascade is a complex amplifying system that culminates in the conversion of fibrinogen to fibrin. This coagulation cascade, or secondary hemostasis, the process is just for clot stabilization. Remember, that's why I said you should watch our video, our lecture on primary hemostasis. Remember, when there is vascular injury, the first thing that happens is vasoconstriction. After that, the vasoconstriction helps to limit blood flow to the site of injury and also and thereby reducing blood loss. And the next thing you have is platelet adhesion to the site of injury, activation, release of granules or content of platelet granules, and then aggregation of platelets to form a mesh-like structure called platelet plug that helps to do what? To block the site of injury to stop more bleeding. Now, this platelet plug that is formed at the stage of primary hemostasis is not very strong and may not be able to actually stop the bleeding entirely from taking place. So we need to stabilize the clot. So the secondary hemostasis comes into, carry out this function of clot stabilization by forming what we call fibrin to enhance the platelet plug to form a stronger clot that will help to do what? Stop the bleeding entirely. So the main goal of secondary hemostasis is called to convert soluble fibrinogen into insoluble fibrin. The fibrin forms a mesh that strengthens the initial platelet plug. This process is actually triggered by coagulation cascade, and it is an enzymatic reaction. Before we go into the secondary hemostasis proper, it's good for you to know that the key features this particular process involves serine proteases, what we call clotting factors, okay? And thrombin is the central enzyme in this particular coagulation cascade. And this process happens simultaneously with primary hemostasis, and it is actually regulated because we don't want unwanted clots being deposited in various parts of the body. So this process is tightly regulated. So let us look at various clotting factors that will be playing different role in this secondary hemostasis. We have the clot factor number one. Number one factor is fibrinogen, and it is produced or synthesized in the liver. We have number two factor. Factor two is prothrombin. Prothrombin is factor two and is produced in the liver. We have factor three. Factor three is called tissue factor. The tissue factor is produced by subendothelial tissue, the subendothelial tissue, the damaged blood vessel. Okay, and we have factor four. Factor four is calcium ion. Calcium is obtained from our diet, or basically from our diet, or from bone mass, but basically from our diet. Okay, we have factor five. Factor five is labile factor. Labile factor is produced, synthesized in the liver, can also be found in platelets. We have factor seven. Factor seven is called stable factor. Stable factor, which is factor seven, is synthesized in the liver and is a vitamin K dependent factor. And we have factor eight. Factor eight is called anti-hemophilic factor A. Anti-hemophilic factor A, it is produced by the endothelial cells, especially in the liver and the spleen. And then we have factor 9. Factor 9 is Christmas factor, which is can also be called anti-hemolytic factor B. It is synthesized in the liver, and factor 9 is also a vitamin K dependent factor. We have factor 10. Factor 10 is swelled power factor, and it is synthesized in the liver. We have factor 11. Factor 11 is plasma thromboplastin antecedent, and it is synthesized in the liver. We have factor 12. Factor 12 is Hedgeman factor synthesized in the liver. And then finally, we have factor 13. Factor 13 is called fibrin stabilizing factor, and it is synthesized also in the liver. All these factors are what actually help in carrying out the enzymatic reaction that brings about the formation of fibrin that stabilizes the initial platelet plug in the secondary hemostasis. Now, the secondary hemostasis, there are two initiation pathways. There are two initiation pathways. We have the extrinsic pathway, and also we have the intrinsic pathway. Now we have the common pathway, which is common to both of them. The common pathway that is common to both the extrinsic pathway and the intrinsic pathway. We are going to look at these pathways in detail. Now let us start by looking at the extrinsic pathway. The extrinsic pathway is the primary physiological pathway that initiates coagulation. Now, what is the trigger for this pathway? The trigger is the tissue factor. Remember, tissue factor is factor what? I just hope that you are following me and you should be able to know what tissue factor is. Now, tissue factor is actually released after the vascular injury. It is released after the vascular injury by the subendothelium. Okay? And it is activated when a vascular injury exposes this particular extrinsic pathway is activated when a vascular injury exposes the tissue factor on the damaged endothelial cells. Now, this tissue factor binds to and activates the circulating factor 7. When the tissue factor binds to factor 7, it forms a complex known as tissue factor factor 7, activated factor 7 complex. And now the resulting complex will then activate factor 10 and factor 9. Now the intrinsic pathway. Remember, the extrinsic pathway is initiated by the trigger is tissue factor. Okay? And this tissue factor comes about from the injured vessel. It is the one that triggers the extrinsic pathway. And it's done by what? Activating tissue factor activates circulating factor 7. The activated factor 7 forms a complex with the tissue factor that goes about to activate factor 10 and then factor 9. Now we are looking at the second pathway, which is intrinsic pathway. The intrinsic pathway, this pathway can be activated by the contact with the negatively charged surface, such as the exposed subendothelial collagen. The exposed subendothelial collagen is the trigger for the intrinsic pathway. And this particular pathway is a longer pathway that begins with the activation of factor 12. If factor 12, when activated, as a result of the contact with the damaged surface, the factor 12 is activated and becomes activated factor 12. The activated factor 12 will lead to sequential activation of factor 11 and then factor 9. Let us look at the cascade. The in intrinsic pathway, factor 12 coming in contact with the damaged surface gets activated, and in the same process goes on to activate factor 11, and factor 11 activates factor 9. Factor 9 activates factor 8 and then goes over to activate factor 10. Now, this particular pathway, intrinsic pathway, also amplifies clotting response, particularly through a positive feedback loop involving thrombin. We are going to explain that further. Now, remember that we have looked at briefly at extrinsic pathway and the intrinsic pathway. Then we are at the common pathway. The common pathway, this is where the two pathways converge. The two pathways converge at the common pathway, the extrinsic and the intrinsic pathway. The role of extrinsic pathway is to activate factor 10. The intrinsic pathway also ends up activating factor 10. So you find out that both the intrinsic and extrinsic pathway converge at factor 10 activation, and then you have a common pathway. So this common pathway begins with the activation of factor 10 by either the extrinsic or intrinsic pathway. The activated factor 10 along with its cofactor, which is factor 5, forms the prothrombinase complex, known as prothrombinase complex. The activated factor 10 plus factor 5, activated factor 5, forms a complex known as what? Prothrombinase complex. This prothrombinase complex is what actually goes ahead to convert prothrombin to thrombin. Now, when prothrombin is converted to thrombin, what follows next? Remember we said that thrombin is actually the central protein enzyme in this particular pathway. When prothrombin is converted to thrombin, the thrombin then does the following. The thrombin converts fibrinogen to fibrin, and the thrombin also activates further factor 5, factor 11, and factor 13, which is a positive feedback mechanism that enhances the coagulation cascade more and further reinforces thrombin production. Factor 13, when activated, cross-links the already formed fibrin to form a stable clot. Now, fibrin strands polymerizes into a mesh that stabilizes the platelet plug when formed, and the factor 13 cross-link these strands to create a firm, durable clot. Now, the sealing the vessel, what we call the sealing the vessel, that is the sealing of the injured site to finally stop bleeding. The fibrin mesh works in conjunction with the platelet plug to provide a stable clot that effectively stops blood flow, thereby preventing excessive bleeding. Now, we said earlier that the thrombin is the central enzyme of secondary hemostasis. Thrombin perform several critical functions in secondary hemostasis. Number one, when thrombin is formed by the activated factor 10 and factor 5 complex, it does what? It cleaves fibrinogen into fibrin that forms, and that does forming the fibrin clot that helps to reinforce the platelet plug that has already been formed earlier. So the thrombin cleaves fibrinogen to form fibrin, number one function. Number two, thrombin also activates factor 13. When thrombin activates 13, the activated factor 13 goes up to cross-link the fibrin strands that already been formed, converting the loose mesh into a strong, insoluble, and stable clot. Now we have another function of thrombin is that thrombin also activates platelets. Thrombin activates platelets. Thrombin activates platelets via cleaving of protease activated receptors 1 and 4. The protease activated receptor 1 and 4 found on the human platelet. So thrombin, when it's formed, also goes through a positive feedback, goes back to activate more platelets enhancing platelet plug formation. And thrombin does this by activating the receptors on the surface of platelet, and these receptors are protease activated receptors 1 and 4. Protein also activates coagulation factors. Now, for coagulation factors like factor 8, factor 5, factor 11, this is a positive feedback, which significantly does what? Amplifies its own production, leading to an explosive burst of thrombin production. Thrombin also binds to what we call thrombomodulin that activates protein C. Activating protein C with its cofactor protein X helps in regulating secondary hemostasis. So you see, when we say that thrombin is a central enzyme of secondary hemostasis, we said that because of so many functions that thrombin is engaging during this process of secondary hemostasis. I've been able to mention about 5 functions: cleaving of fibrinogen to form fibrin, activation of factor 13, activation of platelets, activation of some coagulation factors, particularly factor 5, factor 8, and factor 11, and then activation of protein C through binding to thrombomodulin to also help to regulate the secondary hemostasis. Let us now discuss various laboratory tests or various diagnostic tests that can be used to assess secondary hemostasis. The first on the list is what we call prothrombin time test. Prothrombin time test measures the time it takes for blood to clot after the addition of tissue factor. It assesses the extrinsic and common pathway of the coagulation cascade. Now, PT is used to evaluate the function of factors like factor 1, which is fibrinogen, factor 2, prothrombin, and then factor 5, factor 7, and factor 10. We have another test that is linked to prothrombin time test, what we call international normalized ratio, INR. The INR is a standardized value derived from PT, and it is commonly used to monitor patients on anticoagulant therapy, especially those on warfarin. The second test is activated partial thromboplastin test. This test evaluates the intrinsic and common pathway of coagulation cascade. It assesses the factors like factor 1, factor 2, factor 5, factor 8, factor 9, factor 10, factor 11, and factor 12. It is primarily used for monitoring heparin therapy. We have another test that can be used to evaluate secondary hemostasis. The test is called thrombin time test. Thrombin time test. This test evaluates the final step of coagulation cascade where fibrinogen is converted into fibrin. Prolonged thrombin time test may indicate deficiency in fibrinogen or the presence of inhibitors such as heparin. Now we have what we call another test called fibrinogen test. The fibrinogen test measures the amount and function of fibrinogen, which is factor 1, in the blood. This can be measured either by a clot-based assay, that is assessing fibrinogen activity, or by an immunological assay, assessing fibrinogen antigen proper. It is used to diagnose conditions like afibrinogenemia, that is absence of fibrinogen, or dysfibrinogenemia, abnormal fibrinogen, as well as to assess fibrinogen levels in conditions like disseminated intravascular coagulation or liver disease. Then we can also do what we call factor assay. Factor assays like assessing specific factors like factor 8, factor 9 These tests are performed to evaluate the activities of individual clotting factors. They are used in diagnosis of breathing disorders like hemophilia. Hemophilia is associated with factor 8 and factor 9. So you can do assay for the individual factors. Okay. Now we have another test that we call mixed studies. Mixed studies. Now the purpose of mixed studies is to differentiate between a factor deficiency and the presence of inhibitors being the cause of a prolonged clotting time or a prolonged activated partial thromboplastin time. This distinction is vital for accurate diagnosis and appropriate clinical management. Now, this mixed studies, what is it all about? What is it all about? Like I said, it's used to differentiate deficiency from inhibitors being the cause of prolonged either PT or aPTT. Now, we have the principle is based on the fact that even a 50% concentration of a clotting factor is typically sufficient to correct a prolonged clotting time. Now, the procedure involves a patient plasma with a prolonged PT. You must have done a PT or aPTT on a patient plasma and it's prolonged. Now, it's the patient plasma that you will now use and mix in a 1:1 ratio with normal pooled plasma. This normal pool plasma is obtained from a normal individual. Okay, the normal pool plasma contains full complement of all coagulation factors. Okay, and then you will now use the normal pool plasma, the mixture of normal pool plasma and the patient plasma to repeat either the PT or aPTT test. Now, let's look at the result interpretation of mixed study. If the prolonged clotting time of the patient's plasma corrects after being mixed with the normal pool plasma, when you have must have repeated the test using the mixed plasma, if there is a correction of prolonged PT or aPTT, then it indicates a factor deficiency. The normal plasma provides the missing factors, restoring the coagulation cascade function. In this scenario, the next step will be to perform the specific factor assay to actually identify which factor is deficient. Example, factor 8, factor 9, or factor 11. Okay, so when you do the mixed studies and at the end of the repeat with the mixed plasma, you find out that the deficiency has been corrected. That is, the PT is now within normal range. That means you will suspect that the what is responsible for the prolonged patient PT or aPTT is a deficiency in a particular clotting factor. So what you do is to do what? Go ahead and do a factor assay to actually find out the factor that is deficient. But when if you do that mixed studies and you find out that there is no correction, that the PT or aPTT is still prolonged. Now, if the prolonged clotting time fails to correct after mixing with the normal pool plasma, it suggests the presence of an inhibitor. This is because the inhibitor is an antibody that inhibits or inactivates the coagulation factors, and it is present in sufficient quantity in the patient's plasma to overwhelm the factors provided by the normal pool plasma. So when there is no correction after the repeat, then you suspect inhibitor. Because this inhibitor, they are antibodies and they are present in the patient plasma. So even if you mix with the normal pool plasma, this inhibitor will still act on the normal pool plasma to inhibit those factors, even though they are present in normal pool plasma. They will inhibit them from, you know, working. So when you repeat the test again, this test will still be prolonged. So you suspect an inhibitor. Okay. Now there are special consideration when interpreting, when doing this test, because there are time dependent inhibitors that if you are not careful, you will have false negative result or false positive result as the case may be. So some inhibitors such as specific factor inhibitors, example, inhibitors against factor 8 may not immediately inactivate the factors. In these cases, it is advised that the mixed plasma is incubated at 37 degrees Celsius for 1 to 2 hours before the test is repeated. Okay? And a lack of correction after incubation suggests a time-dependent inhibitor like factor 8 inhibitor, strengthening the suspicion of acquired coagulopathy like acquired hemophilia. Okay, then we have lupus anticoagulant, the most common type of non-specific inhibitor that causes prolonged artificial uh, partial thromboplastin time test is a lupus anticoagulant. Why it can cause a lack of correction in a mixing study, it is usually not time dependent and is typically associated with thrombosis rather than bleeding. Then for this particular one, further spectral tests are needed to confirm the presence of lupus anticoagulant. We have heparin contamination. A prolonged artificial partial thromboplastin time does not correct with a missing study can also be due to heparin contamination in the blood sample. The thrombin time test can help rule this out, as if you do the thrombin time test, it can also be prolonged in the presence of heparin contamination. There's the test that is called clotting time test. This clotting time test, we used to do it before, but it is now obsolete. It's no longer in use. It's no longer being used to evaluate the overall function of the intrinsic, you know, and common pathways as it was used, in the past. This particular test initially was being used to evaluate the overall function of the intrinsic and common pathway, and it measures the time it takes for a blood sample to clot in a glass test tube without any added activators. Now, the limitations, it has a lot of limitations. The clotting time test has a very limited place in modern hemostasis evaluation because it has been replaced by many sensitive and reliable and standardized tests for several key reasons. Number one, insensitivity. The clotting time test is only prolonged in cases of severe deficiencies of clotting factors. It will not dictate mild or moderate coagulation disorder. For example, if a patient with a factor deficiency, a patient with a factor deficiency may even have normal clotting time, even if they have prolonged bleeding time from a platelet disorder. There's also lack of standardization. The results are highly variable and depends heavily on technique and specific conditions like temperature and a special type of glass tube, okay, which makes it unreliable and difficult to compare results within lab. So instead of doing clotting time test, we involve the use of these other tests I have mentioned: PT, aPTT, INR, international normalized ratio, thrombin time test, fibrinogen, and other tests I have just mentioned. Now, regulation of secondary hemostasis. Secondary hemostasis is tightly regulated so that this process does not escalate, to cause injury and do the things that it's not supposed to do. The coagulation cascade is a powerful process that must be tightly regulated to prevent unwanted clot formation, that is formation of thrombosis. This is achieved by several anticoagulant mechanisms. We have what we call protein C system. The protein C system, remember we said earlier that thrombin can bind to thrombomodulin and then activate protein C. So thrombin can bind to a receptor on endothelial cell called thrombomodulin, and the binding changes thrombin's function from being procoagulant to anticoagulant. The thrombin thrombomodulin complex activates protein C. The activated protein C, along with its cofactor protein X, inactivates factor 5 and factor 8, shutting down the common and the intrinsic pathway. So, activated protein C and protein X as a cofactor shuts down the common and intrinsic pathway, thereby do what? Regulating secondary hemostasis through blocking of intrinsic and common pathway. Remember that for this to happen, thrombin has to bind to thrombomodulin on the endothelial cells, and the complex will now end up activating protein C. In the presence of cofactor protein S, factor 5, factor 8 is inactivated. We have antithrombin. Antithrombin is another protein that helps in regulating the secondary hemostasis. It is a major protein that actually inhibits thrombin and other active clotting factors like factor activated factor 10 and factor 9. And when these factors are inhibited, apparently the coagulation cascade is slowed down. We have tissue factor pathway inhibitor. Tissue factor pathway inhibitor, another inhibitor that helps in regulating secondary hemostasis. Okay, this protein released by the endothelial cells directly inhibits initial tissue factor 7 complex, okay, thereby regulating the extrinsic pathway. So you have antithrombin that regulates secondary hemostasis by directly inhibiting thrombin formation and also directly inhibiting some other factors like activated factor 10 and then factor 9. And also we have protein C, activated protein C, that also inhibits the intrinsic pathway by inhibiting factor 5 and factor 8. And we have tissue factor pathway inhibitor that inhibits tissue factor activated factor 7 complex. And when this is done, extrinsic pathway is inhibited. Now, a deficiency in any of these regulatory mechanisms can lead to hyperaggregable state and an increased risk of thrombosis. Now, this is a diagrammatic explanation of what I have just said. The three mechanisms that help in regulating the secondary hemostasis. Number one is activated protein C pathway. This activated protein C pathway is achieved by thrombin binding to a protein called thrombomodulin produced by the endothelium. When this complex thrombin binds the thrombomodulin, it activates protein C. The activated protein C in the presence of protein S now inactivate factor 5 and then factor 8, shutting down the intrinsic pathway. Okay. Now, there's also the second method by use of sapin family, that is serine protease inhibitor. This involves particularly antithrombin. This is the main protein in this particular pathway. The antithrombin goes straight to inhibit thrombin, the formation of thrombin, and then also it can also inhibit the formation of activated factor 10, activated factor 9, and activated factor 11. And then you have some other proteins in this particular set, protein Z dependent inhibitor that inhibits factor 10, and then protein C inhibitor that inhibits activated protein C, and also C1 inhibitor that inhibits factor 11. Now, the third pathway through which secondary hemostasis is regulated is through the non-sapin inhibitor. This is the use of tissue factor pathway inhibitor that inhibits tissue factor 7 complex, thereby shutting down the extrinsic pathway. We also have the alpha 2 microglobulin that inhibits factor 10 and also thrombin in these non-sapin inhibitors. Then after the formation of fibrin clot, we have what we call clot retraction. Clot retraction is the shrinking or condensation of the blood clot that occurs in the hours following its formation. This process is driven by the platelet trapped within the fibrin mesh. What is the mechanism? Platelets contain contractile proteins, primarily actin and myosin. Once they are trapped in the clot, these proteins begin to contract and pull on the surrounding fibrous strands. This action pulls the edges of the clot closer together, squeezing out any excess fluid and making the clot smaller. firmer and more compact. The main function of clot retraction are to reduce the size of the wound by drawing the edges of the damaged vessels together, to compact the clot, and to make it more resilient to the force of blood flow. This process is crucial for successful wound healing and the eventual removal of the clot by fibrinolysis. And that brings us to the tertiary hemostasis, fibrinolysis. That brings us to process of fibrinolysis. The fibrinolysis, which can also be called the tertiary hemolysis, is the final stage of hemostasis, which ensures that clots are removed once vascular repair is complete. Now, during clot formation, plasminogen is incorporated into the fibrin mesh. Now, there is two things that help to activate this. One is tissue plasminogen activator, and another one is urokinase plasminogen activator. Now, the purpose of fibrinolysis is to convert, plasminogen to plasmin. Plasmin is the one that helps to break down the fibrin clots. But for plasminogen to be activated, you need two activators that help in activating them, and they are called tissue plasminogen activator and urokinase plasminogen activator. Okay, they convert plasminogen into plasmin. Now, the tissue plasminogen activator and plasminogen came together on the surface of fibrin clots to which they both bind. The tissue plasminogen activator then activates plasminogen on the fibrin clot, which subsequently cleaves the fibrin. Now, the urokinase plasminogen activator activates plasminogen in the presence of urokinase receptor, and they are found in various types of cells within the body. Now, when plasmin is formed, plasmin digests fibrin into soluble fragments called fibrin degradation products, FDPs, dissolving the clot and restoring normal circulation. How is this process regulated? Remember, the main thing in the fibrinolysis process is the formation of plasmin, and this is done by conversion of plasminogen to plasmin. And conversion of plasminogen to plasmin occurs as a result of two activators: tissue plasminogen activators and urokinase plasminogen activator, that activates plasminogen to form what? Plasmin. And once plasmin is formed, it goes ahead to do what? To break down fibrin clots, forming what we call fibrin degradation products. Okay, this process is tightly regulated. For the process not to escalate, we have inhibitors that inhibit the activities of tissue plasminogen activator and also urokinase plasminogen activator. Okay, so we have plasminogen activator inhibitor type 1 prevents premature plasminogen activation by inhibiting tissue plasminogen activation, while plasminogen activator inhibitor type 2 inhibits urokinase plasminogen activation. Then we have the third protein that is involved in regulating fibrinolysis, alpha-2 antiplasmin. Alpha-2 antiplasmin neutralizes free plasmin, that is, it inhibits plasmin itself. Now, without this type of regulation, uncontrolled fibrinolysis could cause bleeding, while inefficient fibrinolysis can result in persistent clots, forming thrombosis. So these two processes need to be balanced. And the presence of these activators and inhibitors help to do what? To balance this process. This is a diagrammatic explanation of what fibrinolysis is all about. At the final stage of hemostasis is fibrinolysis, which ensures that clots are removed once vascular repair is complete. And this process is triggered by conversion of plasminogen to plasmin, and plasminogen is converted to plasmin by activators, tissue plasminogen activator, and urokinase plasminogen activator. Once plasmin is formed, the plasmin goes ahead to do what? Digest fibrin clot into soluble fragments called fibrin degradation products. And this process is tightly regulated by having inhibitors that inhibit the action of tissue plasminogen activator. Therefore, plasminogen activator inhibitor type 1 inhibits tissue plasminogen activator, while plasminogen activator inhibitor type 2 inhibit urokinase plasminogen activator. And then we have alpha 2 antiplasmin that neutralizes plasmin, thereby controlling the process, making it not to escalate to cause more injury. Now let's look at medical tests, different medical tests that we can use to actually evaluate the process of fibrinolysis. The one among them is called D-dimer test. D-dimer test, this is the most common and widely used test to evaluate fibrinolysis. The D-dimer test is a specific protein fragment produced when a stable cross-linked fibrin clot is broken down by plasmin. The test measures the level of D-dimer, that is fibrin degradation product, in the blood. How does it work? A positive or elevated D-dimer level indicates that a clot has recently been formed and is being broken down. What are the clinical use of this D-dimer test? High D-dimer levels suggest active fibrinolysis and are often elevated in conditions such as deep vein thrombosis or disseminated intravascular coagulation. But it is worthy to know that a negative D-dimer test is actually highly effective at ruling out deep vein thrombosis or pulmonary embolism in patients with a low to moderate pre-test probability. However, a positive result is not specific to these conditions and can be elevated in various other states such as recent surgery, trauma, infection, or cancer. Now we have another test we can use to evaluate the fibrinolysis process, fibrin degradation product test. This test measures the fibrin degrading products, and these degradation products are fragments of both fibrin and fibrinogen that are produced by plasmin. How does it work? Fibrin degrading products are less specific than D-dimer tests because they can be produced from the breakdown of either fibrinogen or fibrin, meaning they do not necessarily indicate the presence of a stable or cross-linked clot. Clinical use: the fibrin degradation product test is often used in conjunction with other tests to diagnose conditions like DIC, that is disseminated intravascular coagulation, euglobulin lysis test, ELT. This is a more specialized test that directly measures the overall fibrinolytic activities of a patient plasma. The test involve isolating the euglobulin fraction of the plasma, which contains key components of the fibrinolytic system like plasminogen and tissue plasminogen activator, but excludes most of the natural inhibitors. A clot is then formed in this fraction, and the time it takes for the clot to dissolve is measured. Now, a shortened uroglobulin lysis test indicates hyperfibrinolysis, that is excessive clot breakdown, which can lead to bleeding, while a prolonged uroglobulin lysis test suggests hypofibrinolysis, that is impaired clot breakdown, which can increase the risk of thrombosis. We have fibrinogen assay. Fibrinogen assay can also be used to assess this fibrinolysis process, but while fibrinogen is primarily involved in clot formation, low fibrinogen levels may also indicate excessive fibrinolysis as fibrinogen is consumed during clot breakdown. We have another test that can also be used. We have plasminogen activity. Monitoring plasminogen activity or assessing plasminogen activity. Plasminogen assay are used to assess the function of plasminogen, the precursor of the main protein in this fibrinogen, which is plasmin. Deficiencies in plasminogen can lead to thrombotic disorder. Now, summary. I'm sure that you'll be able to say in a nutshell what fibrinolysis is, how it comes about, the formation of of plasmin from plasminogen, and how it is regulated. Okay, these are my references. Thank you very much for being part of this lecture. Keep a date with us as we are going to discuss some of disease conditions that can emanate when these processes are not in check, or where there is imbalance in procoagulant processes and anticoagulant processes. Thank you very much for being part of what we are doing. Keep a date with us for the next lecture. Thank you.